Great. I think we have all our presenters here and we're a minute past 11, so we might start. My name's Alex Hall and I'm a member of the National Centre of Implementation Science, and I'll be your chair for today. I'd just like to welcome everyone and say good morning and thank you for joining us today for this exciting webinar, Scaling Up, which is being hosted by the National Centre of Implementation Science. To begin, I would like to acknowledge the traditional owners of the lands on which we're meeting on today. For me, that's the Awabakal people, and to pay my respects to elders past, present and emerging. This webinar today is focused on an extremely important and challenging issue that I think we've all been grappling with in our roles as policymakers, practitioners and researchers, and that is the scaling up of programs and interventions over multiple contexts and jurisdictions, with the purpose of maximising the reach and benefit that such programs have. I think we all understand how challenging this can be, as we're often faced with a number of barriers that can impede this process, with some of the most common including the feasibility of broadening the delivery of a program, ensuring its appropriateness for different areas and contexts, as well as the cost and resource implications. However, today we are honoured to be met with three exceptional presenters who will provide us with some insights and practical concrete examples of how they've tackled this important issue. First up, we will hear from Dr. Lise Lafferty from the Kirby Institute, who will share with us her insights into exploring the barriers and facilitators to scaling up a sexually transmissible infections point of care testing in remote Aboriginal and Torres Strait Islander communities. This will be followed by Dr. Courtney from Hunter, New England Local Health District, who will share with us her experiences with using the intervention scalability tool for supporting the scale up of the Childcare Eats program in early childhood and education care settings. And finally, we'll hear from Niki Kajons from Central Coast Local Health District, who will be presenting on a case study of scaling up a health promotion program, Thirsty Choose Water, across 3 local health districts and 85 schools. At the end of the 3 presentations, we will then open it up for questions from the audience. But please feel free to put any questions you have in the chat function. We will address and answer these at the question and answer time, or you can just pop up your hand during the question session and we can open up the mic for you to ask the questions directly. I'll now pop you over to Lise, who will start sharing her screen and kick off these presentations. Thank you.
I'm sorry to jump in. I believe they might be trying to talk, but it's very, very quiet.
Yes, I can't hear as well. Lise, do you have a microphone or something that you could
better?
use? Yes, that's a lot better. Thank you.
Okay. So I'm going to be talking about the a qualitative study that I led within a larger trial program. So I'll just highlight that program here. So this is the Test, Treat and Go Tango 2. The first iteration of Tango was a randomized control trial looking at chlamydia and gonorrhea point of care testing in remote Aboriginal communities. So Tango 2 was a scaled up version of that trial, and it translated from a trial into a program when it went to Tango 2. And Tango is now in its 3rd iteration of scale up and moving sort of going more nationally. And since I did these interviews in 2018, they have since integrated trichomonas testing as well. So I led this qualitative evaluation to understand acceptability and scalability of point of care testing within these remote settings. So I did interviews with 20 people, including 15 healthcare workers. So that's Aboriginal health workers, Aboriginal health practitioners, sexual health workers, nurses, as well as practice managers and sexual health coordinators. across 7 different clinics. And so we purposely selected these clinics for clinics that were sort of high testing versus low testing clinics. And so that was, where is this point of care device sitting in the corner collecting dust versus where is it really part of everyday use? And so that little blue cartridge thing with the QR code at the bottom of the right screen is that it's the cartridge where you would put the specimen into, and then you put it into this point of care machine. It's got 4 different, you can put 4 different cartridges in at once and run the test. It takes 90 minutes to get a result. And so prior to doing these interviews, having no medical background, I went and did the training for this testing. And I found it a bit cumbersome and complicated. I was cautious or worried about not contaminating specimens, but also there were a couple different software things that you had to do, and they had to be run in particular orders. And so it was a bit cumbersome to learn. So then we have Andrew Malot's Scale Up guide. And so the one on the left is the original guide, and Andrew will correct me if I'm wrong, but then we have it was developed for New South Wales Health, and then that informed this publication on the right. So qualitative research uses a theoretical framework to analyze any findings. And so this is clearly not a framework, it's a guide. So what we did was we took that framework, we took the key definitions or the guide, and we crammed it into a framework using these definitions. So the first one is acceptability, which refers to the degree of support. Now, when we think about healthcare interventions and acceptability, it's often very broad, that definition, the way that we talk about it. And so it's, it's a bit vague. Yes, it had high acceptability, it had little acceptability, people liked it, they didn't. So what does that mean? So Seacon and colleagues came out with this great definition, looking at, there are now 7 components of acceptability within their framework. And so it's affective attitude, burden, ethicality, intervention coherence, opportunity cost, perceived effectiveness, and self-efficacy. So within the interviews that we did, there were these 3: the burden, how much of an impact on your workload, perceived effectiveness, do you get a good result when you use the point of care testing device, and self-efficacy, are you confident in using that device? Another definition that we pulled out from Andrew's framework, in my head I keep saying Malot's framework because that's what we call it where I work, because we don't work with Andrew every day, is compatibility. So it's, how well does it fit within the local health systems where you're trying to implement this new intervention? And then also reach. So I'm going to talk about the acceptability and compatibility on the next couple of slides, but I just wanted to highlight here how important reach was within this, because when we're talking about STI point of care testing within remote Aboriginal communities, it can be high endemic, those STIs in those communities, high prevalence, high transmission. And so point of care testing is really sort of, a rapid test and treat intervention. And so how do you engage people into STI point of care testing in those communities, which was really important finding as well. So some relevant findings in terms of impact for this research was, the first one is self-efficacy. So it's this person who is from a low testing clinic. They talked about if you don't use it regularly every single day, you have to really stop and think. And so they're talking about how do we go from, introducing this device, offering training, to then it just sort of sits over there in the corner because they haven't used it. It's not become part of their routinization process to really just integrate it into their everyday use. And then also compatibility was one of the key findings. And so this person talks about the time it takes for the results to come back. I think that's the critical thing to consider in using point of care technology. And then I should have bold texted this bottom line as well, but the context of that is that local system, health system scenario is that many of these communities are hundreds of kilometers away from anyone, and it's only planes, and planes aren't always going. And so within that, what that means is in that some of these communities, there might be planes that go on Tuesdays and on Fridays. And so if you do a test and you have that specimen that you need to send off to pathology, it's got to go on the plane, but it's Tuesday afternoon and the plane's already gone for the day. So then it's not until Friday. So then on Friday, that specimen goes out, goes to wherever the community where the pathology is, but nobody's there until Monday. So it's been a whole week before you get that result back. And in a high endemic setting, that can be a bit problematic in terms of high transmission when you could have captured it the same day. So last year, there was some federal funding that came through for this national hepatitis C point of care testing program. And so they were scaling up hep C testing using that same point of care machine that the STI testing uses. And so in doing that, they looked at the paper that we led and understanding the sort of nuances of what's happening. And so that self-efficacy really emerged in considering how do you do effective and efficient scale up within this large model. So in thinking about that, you know, ensuring that people are getting comfortable in using this technology, the point of care technology, there was negotiations between the hepatitis C scale up program and the makers of the point of care technology and some other key stakeholders to change the standard protocol of quality control testing from 1 positive test per month to 2 tests per month, inclusive of a positive and a negative. And so that for 4 sites where there's perhaps going to be, you know, dips in patient throughput and dips in testing where they might not have that, you know, ongoing familiarity of using the machine, it really helps to foster that ongoing use so that then it becomes routine within their everyday knowledge and they're not getting lost when they go to use it, which can then be a deterrent to not using the machine. And so then another impact element is this Rebecca Guy, who's led the Olive Tango. She's been involved in an MSAC application to get Medicare rebate for point of care STI testing within remote Aboriginal communities. And so that compatibility finding within our research, as well as some other things, have informed that application, that MSAC application, so that hopefully this can have that broader policy impact as well from the research. So just a couple of key learnings from this is that the first is, you know, I'm a social scientist, so I'm going to spruik qualitative research wherever possible, but I think particularly within a scale-up framework. And I often, you know, I do a lot of work within epidemiological studies. And so there's always numbers, and numbers are great. And they tell us lots and lots of things. They tell us how many, you know, tests are being performed, how many, gosh, I'm going to forget the word, but, you know, accurate tests, you know, and what's going on, but they're not telling us, they're telling us the what, but not the why. And so qualitative research, I think, really gives those nuanced insights into what's going on and can better inform scale up, you know, at a broader level. And it can help to overcome some of those barriers. And I think the hepatitis C program has really shown that they've foreshadowed what might happen for people, and they've already proactively changed their protocol accordingly. So that is predominantly what I've done with this research. I just wanted to acknowledge Rebecca Guy, who has led all of the Tango work, and Carla Trelaw, who introduced me to Andrew's scale-up guide, Caroline Watts, who's leading the MSAC application, and Corey Marcus, who's heavily involved in the hepatitis C national scale-up program, and who was leading that negotiation, I believe, for increasing that. And I wanted to thank everyone here today for having me. This has been an incredible experience and has really forced me to reach out and find out how my research has had impact. And as we all know, that's a really critical thing to what we do. So thank you for that opportunity.
Thank you so much, Lise. That was an excellent presentation and a really good overview of the importance of looking at the barriers and facilitators to consider for scaling up a program, especially in, you know, remote communities where access to resources can be really difficult. We do have a hand up from Vilas. We were going to wait till the end for any questions, but it might I'll just see what. No, okay, we might just wait for the Q&A session just to address any questions. We do have Courtney presenting next, which I think is a really good lead in because she's now going to talk about the ISAT tool. So it leads off Lisa's work really well, who used that framework. Court, I might hand over to you now if you want to start sharing your screen. Excellent, thank you.
Thanks, Alex. Hoping you can all see that okay. So thanks everyone for the opportunity to present today. So my name is Courtney Barnes. I'm a postdoc with the University of Newcastle and work within the Hunter New England Population Health Unit as well. So today I'll be presenting to you a case study of the Childcare Eats project, which used an adapted version of the ISAT tool to assess the potential scalability of the implementation strategies that we used within Childcare Eats. Before I begin though, I'd just like to acknowledge that I'm presenting from Awabakal country today and would like to pay my respects to elders past, present and future. So just to give you a bit of background to begin with, the Hunter New England Early Childhood Education and Care, or the ECEC, or the childcare team, is responsible for providing support to childcare centres to implement health promotion programs, including the Munch and Move program. And I know we've got a lot of health promotion staff on the webinar today, so I'm sure this isn't anything new to you guys. So within Munch and Move, there's a number of healthy eating and physical activity practices that childcare centres are encouraged to implement. And they have a focus on providing a healthy environment for children and encouraging the development of healthy eating and physical activity behaviours. So I guess to date, support provided by H&E to childcare centres to implement these practices has traditionally been quite intensive and potentially not overly scalable. So they're things including workshops, continual contact with childcare services, which can be quite difficult and time consuming given we have over 400 centres in our region and only a really small number of, or a small handful of staff. So we developed Childcare Eats as potentially a scalable solution to address this problem. So previous research tells us that web-based modalities can provide a potentially effective and low-cost approach to implementing nutrition interventions at scale, including those in the childcare setting. Previous research also suggests that the use of such programs to deliver support to childcare centre staff is highly acceptable and consistent with the local infrastructure that they have within the centres. So acknowledging this, we developed the Childcare Eats program to support childcare centres to implement a range of the healthy eating practices within the Munch and Move program. So Childcare Eats is actually based on a similar program known as Go Knapsack, which has been really successful within childcare centres in the US. And for this pilot work, we solely targeted healthy eating in lunchbox centres with the hope of expanding into physical activity and other health behaviours if the program was proven to be effective. So Childcare Eats helps centres to meet healthy eating practices through a simple 5-step process. So firstly, services are encouraged to complete quizzes housed within the program to determine how they're going with meeting the healthy eating practices. So based on the results of the quizzes, centres then develop goals and create an action plan through the program to help them meet the targeted practices. They then use the database of resources which is housed within the program, selecting those resources that align with their targeted practice to meet the goals that within the action plan. So for example, if they were working on scheduling more intentional healthy eating learning experiences, they could use the activities that are found within the program to help them do that. Centres were then encouraged to discuss their developed action plan within the next staff meeting to get the team on board. And lastly, centres were then encouraged to recomplete the quiz to see what improvements they had made in meeting the healthy eating practices. So to support centres to meet the healthy eating practices, we use several implementation strategies. And with that focus of scalability in mind, the strategies were developed to mainly be employed via the Childcare Eats program. So this included audit and feedback, so that was the self-assessment quizzes, the development of a formal implementation blueprint, so that was the action plan, as well as educational materials. However, additional support was also provided by our health promotion officers, including an educational outreach visit, so that was the face-to-face training, and technical assistance, which was through some really short email and telephone support that we scheduled through the intervention. We also supported services to prepare a centre champion, who is a member of staff in charge of advocating for the use of the program, and gained endorsement and buy-in from centre management to mandate change. So given there was extremely limited evidence regarding the scalability attributes of implementation strategies, we undertook a novel approach to evaluate the potential scalability of implementation strategies that we used within Childcare Eats. So the collection of data to assess the scalability of the strategies occurred in 2 phases. So firstly, we did a pilot implementation trial with characteristics of scalability, so the effectiveness, uptake, cost and acceptability of the strategies. We assessed this in 11 childcare centres within HNE. And the second phase was the scalability assessment. So this is where we adapted the intervention scalability and assessment tool, or the ISAT, which was developed by Andrew Millat and colleagues. So the ISAT tool consists of 10 domains and aims to stimulate thinking and promote consideration of the implementation and feasibility factors relating to all potential scale-up aspects of an intervention. These include fidelity and adaptations, reach and acceptability, the delivery settings and agents, and the implementation infrastructure and training. So we adapted the ISAT to focus on the selected attributes of the implementation strategies rather than the intervention, which in our case were the healthy eating practices themselves, to evaluate the potential scalability of the strategies. So specifically, to assess the scalability using the ISAT, the adapted ISAT was employed by an internal working group, and this just consisted of our research team members, including dietitians, health behaviour and implementation researchers, and health promotion staff. The working group collectively completed questions across the 10 ISAT domains, followed by an assessment at the end of each domain to allow a score to be calculated. So following the ISAT process, each domain was scored by the working group on a 4-point Likert scale, so ranging from not at all, which was 0 points, to a large extent, which was 3 points. And we used a consensus approach to scoring each domain within the working group. So some key findings. So from the pilot study, it indicated that the implementation strategies are highly amenable to scale up. The implementation of 4 of the 5 healthy eating practices increased, but this was unfortunately only measured within the intervention group. The implementation strategies were relatively low cost to deliver, and the uptake was high for those strategies that were embedded within the Childcare Eats program, which was really reassuring. Almost all centres reported that using the program was useful in helping centres to meet healthy eating practices, and the implementation strategies were highly acceptable to centre supervisors as well. So when we look at the results from the scalability assessment, the assessment indicates that the strategies are highly amenable to support scale up and received the maximum score of 3 points across 6 domains. So these domains included the problem, the program or the implementation strategies, the implementation strategy costs and benefits, fidelity and adaptation, delivery setting and workforce, and the implementation infrastructure. Unfortunately, we had some lower scoring domains, which included the strategic and political context, as well as the evidence of effectiveness. So I guess the findings of the scalability assessment highlight a need for stronger policy and context support and evidence of effectiveness to ensure that Childcare Eats is actually scalable. So for the policy and context support, so within Australia, funding to support the implementation of health promotion programs within community-based settings, so including childcare centres, predominantly occurs at that state and territory level. So we're quite lucky in New South Wales, government funding is provided to LHDs to support the implementation of these programs, which includes Munch and Move. However, such support doesn't exist in all Australian states and territories, which means that the implementation strategies delivered by the health promotion officers, so that face-to-face training and that ongoing support, might not be viable if Childcare Eats was actually scaled to other Australian jurisdictions which didn't have that infrastructure. So as such, we do need to examine whether the impact of childcare eats is reliant on those strategies that are delivered by our health promotion workforce. And if so, potentially need to think of alternative strategies that could be delivered in those jurisdictions where that support is not available. And just touching on that evidence of effectiveness domain as well. So although the pilot did demonstrate that the implementation of the practices improved, this was only assessed in the intervention group in a small number of centres due to COVID causing a bit of havoc with our data collection. So although those results are promising, the effectiveness hasn't been rigorously tested and will need to do so in order to ensure that that's actually effective in improving the implementation of those practices. And we do need to consider, I guess, the limitations of the process. So we only assess scalability in one local health district with a small number of health promotion practitioners and centres. So future assessments should probably include a sample of health promotion staff, which are external to the research team. As there's no valid way of evaluating the scalability of the implementation strategies, we adapted a version of an existing tool, which was the ISAT, and only select scalability domains deemed relevant internally by the research team were assessed during that pilot trial. Which means we potentially missed some components in the process. So lastly, I'd just like to acknowledge the funding bodies for supporting our work, my PhD supervisors, Serene, Alice, Luke and Nicole, and most importantly, our childcare centres, our parents and children. Thank you.
Great, thank you so much, Courtney. That was really interesting and a nice take on the important considerations of also thinking about implementation strategies when scaling up, not just the program. We'll now hand over to our last presenter, Niki, who will focus on the scale up of the health promotion program across 3 local health districts.
Thanks, Alex. Just checking you can see my screen. Oh, actually, no, that would help. Can you see that now?
Yes, perfect. Thank you.
Awesome. Okay. So thanks, everyone. I appreciate the opportunity to present Thirsty today. My name is Niki Kajons. I'm the Director of Health Promotion on the Central Coast, and I'm presenting on behalf of my whole project team today, the Thirsty team, and I want to recognise their tremendous efforts over the many years this project's been going, and I hope I do it justice today. So I'd like to first acknowledge that I'm presenting today from Darkinjung land, the beautiful Central Coast, and pay my respects to elders past, present, and extend that respect to any Aboriginal colleagues around the virtual table today. So I thought I'd start straight up with the project website because I'm going to have to skip through some of the things a little bit quickly today because I'm focusing on the scale up of Thirsty. But there's so much available on this website if you'd like to be able to dive in a bit more deeply. As the first water pun, didn't even mean that one. So please have a look, and my contact details are on the last slide if you need further information, so please get in touch. Okay, so this is a presentation about the scale up of Thirsty. So I've got a fly buzzing around my head. But it's also a project that's a good example of how we consider scalability across our service. So I just wanted to go into that a little bit first, if I may. So full disclosure, scalability isn't our only priority when considering a new idea, how we pursue it on the Central Coast. So our first priority and our strong commitment is, of course, to improving the health of our community. But we are also interested in improving health outcomes more broadly. So when a new idea comes along, we test it with the questions along the lines of what you see on the screen. So I will note this is not an exhaustive list, and it does depend on the project or the idea, but it gives you a flavour for the types of things we consider. And you might notice that what we do isn't probably considered classical, in that we don't use one formal tool to build in scalability, but I do feel there's good alignment with some of the scalability tools and frameworks that you've heard about. For example, today, the wonderful ISAT. So the type of questions we ask and tend to delve into around scalability include things like, Is it a problem for others? Do they actually care about this problem right now? Or if not, are they likely to care about it in the future? Will the delivery of this depend on a workforce outside of health promotion that we don't necessarily have control over? And if it does, can we look to embed it in structures or existing workforces that exist elsewhere, not just on the Central Coast, because that makes it more scalable? Who else might be likely to or best placed to influence policy if that idea has merit, and make sure you engage those folks right from the beginning? Of course, is it affordable and sustainable? And that's somewhat related to embedding in structures. But with any project, there's still an initial amount of intensity required, and it needs to be of a quantum of money that's reasonable for LHDs if you're looking at scaling. So, and of course, that efficiency of resources is important at a local level now more than ever as well. And we emphasise early and ongoing monitoring of acceptability alongside of effectiveness with our work. Related to most, if not all of these, two very key aspects, and that's relationships developed and awareness of the evidence. So it is important to co-create and engage partners. That's completely crucial, but it really does start well before the idea, and it's part of our culture to invest in relationships. We also have an expectation that our health promoters maintain a thorough awareness of the latest evidence. So any of those conversations they have are likely to be on the right track when they have chats with potential partners. So the project itself, we all know that in Australia we have a health problem, around 1 in 4 children approximately being above a healthy weight. We know that consuming sugar-sweetened beverages, sugary drinks, is associated with lots of that increased energy intake and in turn weight gain. We also know that adolescents drink bundles of sugary drinks. They guzzle it down, and those sugary drinks offer no benefits, and they even displace drinks with nutritional value. So we really need to make a change to that. So essentially, coming back to those questions, it is enough of a problem for others, and they're likely to care about it. In addition to that, we were aiming for a single achievable behaviour change rather than complex multiple changes. And it was a what to do, not what not to do. That's a bit of a tongue twister, but anyone with teenagers would know that you're better off not telling them what not to do. So thinking about that need, we started off with a pilot in 2016 in partnership with our local immunisation nurses. So again, a workforce that exists across the state. Utilising that time post-vaccination where Year 7 students are waiting, and that delivered an intervention about choosing water as the drink of choice. So we're fairly comfortable that this workforce could potentially be utilised if the idea took off. Then along came the funding opportunity in the shape of a translational research grant. So at the expression of interest stage, we engaged with partners, including those likely to influence policy. Coming back to those initial questions, so policymakers in the Ministry of Health, and of course cross-agency partners in the Department of Education at all levels were engaged at that point. Following feedback from the TRIGS panel, we expanded the idea to include educational material in the classroom to support that message that was delivered at immunisation time, and also chilled water stations, and this made it more aligned with the Health Promoting Schools model. So with the project structure now utilising that existing well-known evidence-based model, that was really seen as a strength of the project, and it inspired confidence from our prospective scale-up partners. So we built on local health promotion relationships with schools and closely monitored the acceptability each round through the pilot, round 1 and round 2 of the pilot, and the TRIGS, and then also the MRFF. Oh, I think I skipped through that part. There's been another arm of the study, but more on that later. So there were strengths related to scalability that crossed each domain of the Health Promoting Schools framework. So for example, in the curriculum, teaching and learning domain, there was strong alignment with the Stage 4 PDHPE curriculum. Schools loved those lessons and resources, and we've had feedback that they're actually embedded and used by schools to this day. In the next domain, culture, ethos and environment, the quality of the chilled water stations was absolutely crucial. We needed to make them adolescent proof, and a lot of work went into that, and thus again ensuring this could be scaled up to you know, any type of school, wherever it was, with success. Just as an aside, the chill water stations tended to have cross-curriculum application, and this was quite a positive for schools. So again, increasing that buy-in. Immunisation, in terms of home community and partnerships, the immunisation nurses did embrace the opportunity and saw it as a good opportunity to deliver a health message. There was variation in how enthusiastically. So we know that if we needed to, if this was to be scaled up, we'd need to do some more engagement with that workforce. Just to note, the Department of Ed's asset installation of the chilled water stations really showed their support, and it lent us the opportunity to actually do some more translational work, because they did actually fund installation in all government schools. So we came up with a 2x2 factorial study testing 2 interventions: the behavioural intervention, which was based on that health promoting schools framework that I described. Group 2 had chilled water stations installed with nothing else. Group 3 had both, and Group 4 was our control. So these were the outcomes. I'll just touch on this. There's more information to come. The results are not actually published. We're still under review in the journal article at the moment, but spoiler alert, it worked. So it did decrease sugary drink consumption, and it did also increase water consumption, although not statistically significantly. There was moves in the right direction. So that was reassuring. It actually worked. It did have a difference, did make a difference to students. Sorry, my light has just gone off. I'll wave my arms around. Okay, we then had the opportunity to utilise the underspend from the translational grant that mainly came about through Department of Education funding the installation in the public schools. So the advisory group supported the development of a suite of resources, and really that was all designed to make Thirsty accessible to anyone. So we already had a project website, but we really switched that and revamped it to be more outward facing and to have a broader scope than being focused on the research studies themselves. All the materials were co-designed with teachers, students, Department of Education involved in that. And again, drew on the latest evidence for this cohort. So looking at things like gamification, which you'll see very shortly. So I'm about to make you all a little bit dizzy and flick through some slides, but as I said, they're all on the website, so please take the time to have a look around. We had a toolkit which was basically ready for the teachers to pick up and run with anything they needed to make this happen in the school, including the classroom. Clicking on. Oh, sorry. There we go. Oh, is that still? My screen's gone blank. I don't know if that's...
Yeah, no, I think it's gone blank for us too, Niki. It's just a white screen at the moment.
Excellent. That isn't what I had planned. I know things are getting a bit busy. Sorry, just bear with me. Is that better?
Yes, that's much better.
Okay, right. Sorry, I don't know what happened there. Apologies for the tech issues. There's a fundraising pack. We know chilled water stations are expensive. So there was a fundraising pack developed in conjunction with our partners with Cancer Council, who are good at fundraising, and to help schools along the way with that. And we know they're using that to fundraise for more. Oh, it's gone white again. I wonder why it's doing that. Sorry, guys.
If you skip over that next one, does it go to the next?
It's really not. It's just blank. I can just talk through a little bit, I suppose.
Yeah.
There's a game. We've got a game in the App Store, Aqua Sprint. I highly recommend you have a look at that on the App Store of your choice. So again, in that cohort of adolescents, games and apps and things are, you know, engaging, and we've had an app developer do that with, you know, it has educational materials involved as well. It's still not working, is it?
No, I can try to, I've got your slides if you want to try here, or if you're happy just to keep talking, I think that's fine as well, Niki, because that's the most important part is.
Yeah, sure. Okay. I'm more than happy to. Sorry about that. I can send the presentation out afterwards, but it's a shame actually because they look great. So it's a shame you can't see them, but please do have a look on the website. So
if you want to stop sharing, I can try and share mine while you're talking. So that way, if it does come up, that might support the
just let me,
session.
yeah.
It wouldn't be a Zoom webinar if there wasn't some technical issues.
Yeah, and it's going to be me because I don't.
No, it's usually me. Yes, excellent. If you want to keep talking, and I'll see if I can share mine while you're going.
Yeah, sure. It's crazy. Okay, sorry guys. All right. Where was I? Gamification. So there's a game. We have. Oh, it's even stopped at my end. That's all right. Okay, so we've moved on to other translational activities in an effort to. Oh, thanks, Alex. That's awesome. Okay, so the fundraising pack. That's where we got to. Next slide. I think we probably need to flip through that a bit quicker now. Next slide, please.
Can you see that?
It stopped on fundraising.
Okay. Oh, sorry, I'm having.
It's really not playing nice, is it?
It is not. Okay, I might just stop sharing. And if you want to just quickly,
sure.
if you want to just
Sorry, everyone. Okay. So we have had other translational activities. Some have worked, some have not worked so well. We introduced a concept called Friends of Thirsty, which really laid out all the resources for schools and invited them to receive all the resources they would need to run Thirsty in their school, and some level of support from our team. Hasn't been all too popular, so that one we'd say probably hasn't hit the mark. We did, the second arm of the study was through some funding from the MRFF that involved schools from a further 2 local health districts, and further tested the idea in regional settings, which was helpful to understand the impact in a different context. And then using a similar kind of concept with the MRFF, the unspent funds, because we had some support from the Department of School Infrastructure for installation, we actually conducted an audit, which was to build a picture of what the situation is with chilled water stations across the footprint of the study, more broadly, what teachers saw as a concern around sugar sweetened beverages, and also building the case for further translation. So with that study, we actually utilised volunteers to conduct the audit, which was allowed us to spend more money on chilled water stations to incentivise responses. So I'd encourage you to explore in your own teams if you're able to utilise volunteers. They really enjoyed that type of work. We've also run a competition. We've developed a structure to have a competition, and that can be applied anywhere. So it's a great way to open up or build on a relationship with local high schools. And we know that's something that will be asked of LHDs in the near future. So that's something that can really open up that conversation with high schools. We know chilled water stations are a really popular incentive for engagement, and it does link with Department of Ed priorities, the competition, in that it encourages student voice and leadership and aligns with curriculum requirements as well. Currently, the stage of Thirsty is that we are in the middle of, we're just starting off a pilot in primary schools. So this has come about from some funding from the Aboriginal Environmental Health Unit at the Ministry of Health. So we're trialling in some local primary schools to assess how it might work in that context, adapting the resources as we need to see if that is a feasible option for that setting as well. It would have been nice to show you a great testimonial. We've had lots of positive feedback throughout the different arms of the study. acceptability has been high. I really liked your thoughts though, Lise, on around what does acceptability really mean. So we'll give that some thought. I think that's actually a really good point. So we'll give that some more thought about delving into all the different aspects of acceptability. So yeah, sorry this hasn't quite worked out, but hopefully you've got a taste of where the project stands today. It's really gathered momentum and continues to grow. And we did examine scalability at each stage, and that assisted with our decision making on which way we might go with certain things. And it means any planned scalability can be progressed, but it also means we're open to capture or capitalise on any opportunistic or unplanned prospects. And we've really planned it to be set up that way so it's ready for those opportunities. So my apologies for the tech issues, and sorry if I've had to skip through things, but that's the end of my presentation. Thanks, everyone.
Thank you so much, Niki, and thank you so much for handling the tech issues so well. I swear you cannot have a Zoom webinar without some kind of glitch, and you like breeze through it like a pro. Thank you so much.
Thanks. Don't know about that, but thank you.
No, and thank you to all our presenters. I think we've got some really great insights into, I think the whole process of scalability, from looking at barriers and facilitators to planning through the use of planning tools to actually applying it into practice as well. So really great insights. I will open up the forum now if anyone has any questions for our presenters. Vilas, you've been waiting so patiently, so we'll start with you.
Yeah. My name is Vilas Koi. I'm a research and evaluation manager with Southwestern Sydney LHD Population Health. In fact, I have 3 questions for 3 presenters, but in the interest of time, probably I would ask the most important one. This one is for the Niki Thirsty Choose Water program, because I'm associated with the Growing Healthy Kids initiative in Southwestern Sydney LHD, which is something to do with the childhood obesity prevention program. So the Thirsty and Choose Water is one of the interventions we actually look forward to. Thank you so much for giving those insights. They're very useful. But based on my understanding, there are 3 scalability factors or success factors when you want to scale up a program. One of them is the strong leadership or governance. Second one is active engagement of range of implementers. In your case, one of the very strong implementing partnership probably is Sydney Water. So Sydney Water, we actually interviewed them as part of one of the organizational impact and uptake programs for Growing Healthy Kids initiative. And they always say that we are interested for a pilot, but when it comes to scaling up, it requires a lot more in terms of acceptance of policy, having resources, setting up of those water stations across the schools. When we are saying scaling up water stations across all the schools means, all these factors comes into. So probably a comment is that active engagement of these kind of influencing partners is very, very challenging. My comment, probably you can reflect via an email, we can discuss later. And the third one is tailoring some of these programs to the local context, because what happens in a pilot doesn't happen across the whole nation or across the state. There are issues. That was one comment. The second comment is the qualitative evidence that was presented by the first one. I think it was the Lise Lafferty presentation. To me, I have a solid background in qualitative assessment. I noticed actually evidence, hierarchical evidence, mixed evidence, evidence that comes from just qualitative is not sufficient to influence the policy and those who actually, in fact, deliver what we want to actually deliver. So my question is whether the qualitative evidence, which obviously lacks with number of limitations, including in that particular program, it is only 20 people being interviewed. It's not definitely representative. All those things will happen. So scaling up probably requires much more than that actually. So in terms of a qualitative evidence being actually followed up by quantifying that evidence across the states and across the nation. I think some of that, so we lack a rigor in evidence, a scaling up in evidence through multiple sources. So one of the things that's being accepted is multiple sources of evidence. I'll just leave it with my comments, but we can actually discuss some of these ideas later. Thank you so much. These are not questions, these are just comments. These.
No. Thank you very much, Vilas. I think that was really some important points. And I think like Lisa's presentation was really good in terms of delving into untangling some of those issues that we get from the quantitative data with that real richness of the qualitative data in like how to, what are the main barriers and facilitators that we might need to consider with trying to scale up a program and an intervention, particularly when it's far away from some of the resources that we take for granted in major cities. But some really good points there. Thank you so much. And I might lead with a question from that to Niki about the engagement, because I think that was another important point that you brought up, was the importance of engaging with partners. And you were saying that that was something that you really did with your program, Niki. And I was just not shocked, but it was the fact that it was one of the partners was immunization nurses, something that wasn't, I guess, aligned with the content of the program that you were positioning, but really important in terms of the personnel and getting it integrated within the organization. How did you identify that they were key partners when that's not something that you might look for when you're looking for partners for such a program?
Yeah, good point. I think really what happened was that we are co-located with public health, where the immunisation nurses sit. We have conversations, and really we had talked about that time period after immunisation being really quite opportunistic for health message delivery. You've got a captive audience. They have to wait for 10-15 minutes. May as well give them something constructive to do. It actually suits the nurses as well, because the kids aren't just trying to, you know, disrupt each other. It gives them something to engage them. So it had things like distractor cards as well. So while the needle was actually being given, they could, you know, find water on a page. So it served the purposes of the nurse. So that could be used for any health message, really. It's not necessarily just about thirsty. It was more about the mechanisms for how you make that work. So that was part of the translational grant model. It didn't actually happen when we did the MRFF arm of the study for various reasons. Was when COVID started, so immunisation nurses were touch busy, and really things were getting a little bit crazy. So it didn't happen there. And as I said, that workforce would need some more engagement, because there's quite a lot of variability. There is a workforce across the state, but there's variability in how they're structured. So yes, engagement's important at a higher level, but you need to be able to work with the local teams to understand what the opportunity is.
Some great insights. And do we have any other questions from the floor, so I'm not taking up all the time? Don't have any in the chat. I have a question for Lise. One of the things that you identified as really important was that integration within the service of that was something that was a key barrier, I guess, or facilitator, depending on which way you're looking at it. Did you find any insights or anything in terms of key points of how to get a program or an intervention integrated within or routinized within the actual organization that you're hoping to scale up in?
That's a great question. Thanks, Alex. One of the things that I didn't talk about that we touched on within the Scale Up Guide was, and Alex Andrew Malak so pointedly highlighted the role of champions within health interventions. And so having champions within clinics, you know, whether it be the practice manager or another sexual health worker or an Aboriginal health practitioner, it didn't matter who it was, but clinics where there's somebody who really sees the value of the intervention and is able to just run with it, that has that trickle down effect. You know, they're encouraging other people to use it, or they're the go-to if other people get stuck and, you know, they see the value, but they just can't quite get it to work for them. There's somebody within the clinic then that they can have as the go-to, so that having that champion is really helpful. And we've seen that in other studies where we've used the Scale Up Guide as well.
Fantastic, it's great advice. And I think something important, not just for scalability, but the sustainability of a program as well. Court, I had one question for you as well. I think the thing that really struck me about your program was the focus on the implementation strategies. I think sometimes when we're thinking about scalability, we're thinking about the program, not the strategies that go around that. How important do you think it is to think of the scalability of the actual support that we provide, and when do you think that we need to consider that, like at the same time as choosing the program, or any advice?
I think from a health promotion perspective, I guess we've got the luxury of having a health promotion workforce that can provide that implementation support. But I think, you know, regardless, I think we need to consider it at the start. It's a lot easier to provide really intensive support if you're doing a pilot with a really small number of childcare centres. But I think, as I mentioned, like we've got over 400 centres in our district. So, you know, even potentially being able to do a face-to-face training session with all those 400, you know, the scalability probably potentially isn't there. So, yeah, I think really important from the start for us, regardless of what health promotion program, we've developed, rather than, I guess, getting to that fully powered implementation phase and, you know, having that being effective, but then potentially not being scalable, and we've kind of gone too far down the track. So yeah, I think quite important from the start.
Great, thank you so much. And we are, I do notice, at time almost, so we might wrap it up there. But if anyone has any questions for the presenters, please feel free to email us through NCOIS and we'll pass these on. I'd just like to end by thanking everyone for attending today, and particularly to Lise, Courtney and Niki for some great presentations and just some really useful knowledge and insight into what to consider scalability. And I think just to end, I was just going to make some final points I think that came up that were really important when we're thinking about scaling. And I don't think we'd argue with this. It's actually really important for us to do this to maximise benefit and improve health and reduce waste, and to do this early. I think it's clear from the presentations that we need to consider the barriers and facilitators to scaling up and how we might address these. And I think from Niki and Lise and Court's presentations, it's clear that there's some key questions and tools that might help us to plan for some of the challenges early on, so that we can address these early on and improve and ensure scalability of our programs. And finally, I think a final note that, again, we won't disagree with is that it's really important that we consider the resource and cost implications when it comes to scaling, and to consider this really, really early on. Again, thank you everyone for joining us today. We really appreciate it. Meg's put in her email address, so if you do have any questions or comments, please feel free to email those through. Thank you.
Thanks, Alex. Great chairing, great facilitating. Thanks for the opportunity. See you guys.
Thank you. That was really, really insightful.
Thank you.
Thanks, everybody.
Bye.